Thank you very much for the opportunity to speak with you this morning. I think one of the things that we've been focusing on today is this twofold proposition, which is what are we paying for when we're paying for cancer care? And the other part of it is how do we do this sustainably? And part of we get a sense of this morning is that in order to understand what we're paying for, we really have to have a sense of cancer outcomes and the goals of care as an evolving, dynamic value proposition. So as we push forward and really get towards higher cure rates, the technology, the services are vastly different, and perhaps the reimbursement structure has to recognize the rapid dynamic structure of what's happening in cancer care. So I'd like to pose a question to you. So what percentage of men and women today, of everyone in the population, will eventually be diagnosed with cancer in their lifetime? All right, well, we'll come back to this number. So, for many patients diagnosed in 2015, cancer is curable. Through advances in basic science and medical technologies, devastating diseases can in fact be more effectively treated, but cures are not universal. Part of what is inspiring the move towards curing greater patients, however, isn't just rearranging the same old services and technologies that we had 20 years ago, or 30 years ago, or 40 years ago. The availability of targeted immunological agents and molecular-based therapeutics is making a profound difference in patient outcomes. And this is just a photo from our City of Hope patient transplant reunion. We're a transplant center as well as a center that specializes in the care of patients with blood cancers. We've performed more than 13,000 bone marrow transplants, and the survival rates that we've achieved have been largely predicated on the ability to leapfrog technologies very quickly. I'm sorry. So this year alone, 1.6 million people are projected to be diagnosed with cancer. And the lifetime risk of being diagnosed with cancer is approximately 40% for everyone who's born. And this includes, or does not include rather, non-melanoma skin cancers. The flip side of the coin, however, is that more people are surviving. As of January 2014, there were 14.5 million survivors, which translates into roughly 1 in 22 Americans. So all of us, directly or indirectly, have been touched by cancer in our lifetimes. Between 2005 and 2011, we finally, through the SEER database, saw the highest level of cancer overall survivorship that we've seen since the beginning of the registry, with nearly 67% of patients diagnosed with cancer surviving more than 5 years. Unfortunately, if you invert that equation, more than 30% of patients still succumb to cancer in this short period of time. So for patients with advanced and refractory cancers, a cure may not yet be possible. So how far have we come? And I'm going to steal a little bit from Dr. Mike's presentation in that we've moved from the era of histology to the era of molecular biology. So previously we described cancers as they appeared on a slide, and that gave us only the most crude and rudimentary description of the diseases that we were treating. Through advances in molecular biology, genomics, and now proteomics, we now have this deeper, richer sense that cancer is profoundly diverse. And as you heard earlier today, we've moved from an era where 10 drugs are treating 100 cancers to where 100 drugs may be used to treat what we would traditionally have thought of as 10 cancers. And over this time, there's been an extraordinary evolution in our thinking. I remember in the 1970s when Time magazine, our infamous friend, had on its cover, "Magic bullets will cure cancer." Those were the interferons, which didn't quite pan out to what we hoped. But our initial naive belief that there was an inherent simplicity to cancer has actually yielded to a much more sophisticated, deep-seated understanding of the inherent complexity of malignant disease and the need to understand this on a very, very deep molecular level in order to come up with these true precision medicine solutions. So looking at the history of medicine, this is where we started. And I'm going to speak from the perspective of blood cancers. I'm a hematologist, I'm not a solid tumor doctor. So our understanding of cancer goes back to Thomas Hodgkin in the late 1800s and Rudolf Virchow, who respectively described Hodgkin lymphoma and acute leukemia. Histologically, this is what Hodgkin lymphoma looks like with the traditional owl eyes for the malignant cells. And this is one of my most hated foes. This is acute lymphoblastic leukemia. But when you look at these slides, it actually tells you vanishing little about the diseases that you're seeing. And that really, that evolution is reflected in how we treated this. For many years, when I started caring for patients with ALL, the traditional treatment was DVAP, drugs that we'd had forever. And in that setting, we had very, very poor cure rates. It's only by moving forward from an early paradigm to a much more mature one based upon understanding the biologies of cancer that we've moved. So just a quick overview of cancer therapeutics. On the heels of World War I, we discovered that mustard gas could affect tumors. We subsequently developed chemotherapy based upon that, with alkylating agents being the first in class. Subsequently, radiation therapy was also seen to reduce tumor volumes, and the development of linear accelerators led to the initial cures of Hodgkin lymphoma. And then by the early 1970s, combination chemotherapy, initially for Hodgkin lymphoma and non-Hodgkin lymphoma, were made possible through research at the NIH. And these modalities persist today. This is robot-assisted prostatectomy, by the way. But we still use surgery, chemotherapy, radiation therapy. This is someone receiving tomographic radiotherapy as part of a blood stem cell transplant. But these three modalities, no matter how much you shift them around, are of limited effectiveness. So the great leap forward has to come by viewing cancer in a far more specific way. And that the bones of this began with the discovery of the Philadelphia Chromosome. This was initially described in 1959 in Philadelphia, and eventually, through the work of Janet Rowley, we figured out that this was not a random chromosomal abnormality. It actually represented a specific breakage and linkage between chromosomes 9 and 22. This really gave us the sense that a specific genetic abnormality could form a specific disease, and this understanding in turn led to the development of the tyrosine kinase inhibitors. So here, in fact, is the Philadelphia chromosome, where you see the first of these arrows. You see an extra piece of DNA derived from chromosome 22, and you see a reciprocal translocation in that there's a piece missing from the little chromosome 22 below. And what this results in is a fusion product, a protein, which is a tyrosine kinase inhibitor. And here you can see how a very specific drug called imatinib can bind to that groove, so this tyrosine kinase inhibitor can no longer put ATP or phosphorus onto proteins. Very powerful understanding. And we also have now the technology to detect low levels of tumor, residual disease. This is a fish study demonstrating normal BCR-ABL on the left and the rearranged abnormal signal on the right. So we can detect very low levels of tumor expression so that we can judge the effectiveness of our therapies. And what we've seen, and I'll give you my perspective, is CML used to be a miserable disease to treat. If you didn't get someone to transplant in the first 12 months, they inevitably did poorly. The median survival was roughly 3 years, with many patients truly suffering throughout that. And I remember taking care of many patients, giving them oral busulfan in a last-ditch effort. The TKIs have completely upended what we knew about this, and many patients are not only having complete hematological remissions, 98%, but we see 90% effectively molecular remissions with this therapeutic intervention, turning this disease into a chronic illness like diabetes rather than to something that we would normally think as being an imminently devastating disease. Again, Time magazine crystallized this moment by saying we now have new ammunition in the war against cancer. So I'll tell you the insights, though, that we have from this revolution, which is cancer originating from a single tissue aren't singular in their nature, the biology, or the prognosis. Generic words like leukemia and lymphoma, which are the mainstay of what I do for a living, have become almost meaningless in therapeutic decision-making, and in fact, therapy is now driven by the biology, including the molecular biology, and for this we need diagnostic precision. So when I talk about acute leukemia, I'm talking about more than 30 different diseases, and if I give this talk in a year, I'm likely to be talking about more than 50 different diseases. Similarly, with non-Hodgkin lymphoma, when I started out, there were 10, described by histology in the working formulation. Now we're at more than 65 different types defined by molecular subtypes, flow cytometry, and other technologies. So The magic in anti-cancer magic bullets is based upon a deep-rooted understanding of the molecular biology of these diseases. And in order to treat cancer more effectively, that level of granularity will increase. Because as you think about the human genome, there are more than 20,000 genes in the human genome that culminate in 17,000 to roughly 21,000 proteins in the human proteome. That's the scope of what we have to explore in order to fully move forward. So we need to differentiate cancers on not only a molecular, biologic, and immunologic basis, but then we have to make the next step, which is to fully leverage that information in therapeutic decision making. So these advances lead to more effective risk stratification. And what I'll say is that as we move towards discussions of payment, I don't think you can have a meaningful discussion of payment unless you include risk. Because the therapeutics differ so profoundly based upon molecular, genetic, and proteomic risk, the therapeutics should probably be well matched towards those risk levels. We do that very poorly today when we work off of ICD-9 and ICD-10 codes, which are really wastebaskets for describing cancers, particularly blood cancers. As we move forward and understand things like mRNA related to a particular cancer, coming up with specific targeted therapeutics like siRNAs, moving towards addressing abnormal proteins through TKIs, and using epigenetic drugs give us a sense of all the potential range of targets for advances in cancer. So let's take a disease with which I have some familiarity, ALL. I serve on the NCCN panel as a co-chair for ALL practice guidelines. So we can see that ALL isn't one monomorphic disease. I showed you the slide of ALL earlier, but when you look at a genetic level, we can see why children tend to have a better prognosis because they tend to have hyperdiploidy. They tend to have the TEL-AML1 gene rearrangement, all of which are associated with a more favorable prognosis. On the other hand, adults tend to have the Philadelphia Chromosome, rearrangements of MLL, and T-lineage disease more commonly. This gives you, without delving into deep molecular biology, a sense of how chromosomes inform risk, and subsequently risk informs therapeutics. So this is a little bit more detailed. There's a subset of adults and some adolescents who have a far more aggressive form of ALL. No one really understood why. This is a study published in the New England Journal of Medicine that describes molecular abnormalities associated with Philadelphia Chromosome-like ALL. And what you see is that they're abnormalities of multiple genes. And by sequencing patients' DNA and performing a genomic analysis, you can see clusters of abnormal gene function within these patients that point towards therapeutic targets that we can act upon. Again, we go from DVAP to now having patients cluster in a genomic-based informed understanding to point towards drugs that may in fact be profoundly effective in treating these patients. So this gives you a sense of the quantum leaps in understanding the disease and then subsequently acting upon the specific biology. And just to take us a step further, as we look at these microchips that are able to assess 10, 20, 40, 70,000 genes at once, beyond the histological appearance of a tumor, we can see that on a genetic, molecular, and genomic basis, the different types of cancers, different types of lymphoma, who for all the world look exactly the same on a microscope slide, cluster out into different areas, and each one of these should be treated in a way that respects the molecular biology. These are the insights that are leading towards cancer cures. So just to go back to the example of ALL, in the 1950s, ALL had a hideously poor outcome. If you recently saw that TV show, The Emperor of All Maladies, you got a sense of how dismal that was. Through advances in combination chemotherapy, the use of CNS prophylaxis, intensive therapeutics, and then finally risk-adapted therapy that respects the genomic abnormalities, we've been able to advance cures in patients with ALL. This is a paradigm that I hope to visit as we understand the biology of more diseases. So the profound evolution in the therapeutic approach is that surgery, chemotherapy, and radiation therapy have in many ways been supplanted and often replaced by biological and targeted therapeutic technologies. Some of these include the TKIs, some of them for CLL, for instance, and non-Hodgkin lymphoma include the Bruton kinase inhibitors, IMiDs for myeloma and non-Hodgkin lymphoma, proteasome inhibition for myeloma and non-Hodgkin lymphoma, and ruxolitinib for myeloproliferative disorders. I mean, these are all targeted therapeutics. And just to give you one example of a disease that has long been the bane of my existence, it's multiple myeloma. And this is one of those diseases for where genuinely for 40 years we made no progress. And now, based upon a constellation of novel agents, we finally see patients doing much better. These are historical data where nothing budged, and then finally we're seeing the fruits of targeted therapeutic interventions. And when you look at a trial of patients with multiple myeloma treated with a triplet combination of lenalidomide, bortezomib, and dexamethasone, not receiving transplant, we're actually seeing quite extraordinarily success rates in these patients that would have been unimaginable years ago when I started treating people with multiple myeloma. So what's the next frontier? Well, immunotherapeutics, harnessing the power of the immune system, is becoming increasingly powerful in terms of its role in investigation, but also translating into real therapeutics. The key benefits of this are non-overlapping toxicities with traditional chemotherapy, the ability to target tumor cells specifically, and then a treatment effect that can last well beyond the infusion period. So our armamentarium includes not only monoclonal antibodies, but monoclonal antibody drug conjugates, bispecific antibodies, and more recently T-cell-based therapeutics, including chimeric antigen receptor T cells, or CAR T cells. So let me run through some of the targets here. So these are potential targets for monoclonal antibody technology. These are for patients with lymphoma. We've got CD19, CD22, CD52, and CD20. And then commensurately, we have treatment possibilities with rituximab, alemtuzumab, inotuzumab, and blinatumomab. So these are targeted therapies that would have been unimaginable 20 years ago and now have become and are becoming mainstays of therapy. So how do these kill? Well, effectively, we're harnessing an effect that's normally found within the immune system, in which a monoclonal antibody is linked to the target antigen on the surface of a cell and induces complement-mediated lysis. This is how Rituxan largely works. Blinatumomab is a different drug. It's a drug that's been used very successfully for patients with relapsed and refractory acute lymphoblastic leukemia. For patients with B-cell disease, approximately 90% of them express CD19. And what this drug does is that it's basically two antibodies with the functional portions of them opposed to each other. So there's an anti-CD19 antibody linked back-to-back with an anti-CD3 antibody, and this effectively brings a T cell in opposition to the tumor cell, which leads to granzyme perforin-related killing of the tumor cell. So again, approximately 75% of adults have ALL of B-cell origin. More than 90% of them express CD19. So this is a profoundly effective drug for short-term bringing patients into remission. The risk of this is that for patients with a high leukemic burden, they can actually get a cytokine storm, and there's some risk of neurological toxicities associated with this agent. But in using this, we're able to take patients who would have died and use this agent as a bridge to transplant and subsequent cure for these patients. Again, immunotherapeutics providing a novel opportunity for curing previously incurable patients. And again, the complete responses are quite extraordinarily high, with 80% of patients treated with this agent achieving a molecular complete response. This is a level of response, again, unimaginable with virtually all the salvage therapies that we have for ALL. Another agent which is not yet FDA approved but completed a registration trial is inotuzumab ozogamicin. This is a drug which is a monoclonal antibody drug conjugate, and the way it works is that it binds to CD22, which is found in a large number of patients with B-cell ALL. It enters into the cell where the antibody and the drug separate, and then subsequently the drug, calicheamicin, is able to cause double-stranded DNA breaks and kill the tumor cell. So again, a very, very novel agent. And again, in 90 patients who were treated in a trial, 19% have achieved a complete response. 30% of them achieved a complete response without platelet recovery. And many of these patients, again, were able to go on to allogeneic stem cell transplant and have the option for a cure. And again, this agent is awaiting FDA approval. So a final new therapeutic that I'll talk to you about are the chimeric T-cell antibodies. And in this case, chimeric antigen receptor T cells, where we take peripheral blood mononuclear cells from people, we separate out the T cells, and then we use a lentiviral vector to transfect these cells so that they will in fact express a new T cell receptor targeted at, for sometimes when we're treating blood cancers, CD19. And what we're able to do is re-engineer the patient's immune system to express these new T cell receptors, and the target cells can be killed by T cell specific tumor killing. Now, there's some significant toxicities that can happen in patients with large tumor burden, but in many patients who were previously refractory to chemotherapy, these drugs in phase 1 trials have been able to produce quite profound responses. And in addition to the fact that you can get a profound response, there's also persistence of these cells. So unlike chemotherapy that may be gone within 24 to 72 hours after infusion, you've now created a living, almost breathing component of the immune system, which persists long beyond the period of infusion. So in phase 1 trials from these institutions, we've seen complete remission rates of up to 90% in high-risk and refractory patients. This is currently in phase 2 trials, but it's likely to become an important part of this cancer armamentarium. So getting back to our initial question, is cancer curable? I think for the first time we have the tools necessary to find cures for many of our patients. For much of the duration of the war on cancer, we were unable to ask the right questions. We're now poised through advances in technology to ask the right scientific questions that in fact can translate through research to the cures that can really change this equation for patients broadly. The frontier of new therapeutics is largely limited only by our ability to understand distinct genomic and proteomic basis for each cancer. And I'm hoping that over the coming decades, this will translate into increased ability to cure patients. I think getting back to Dr. Mike's discussion of us having puppy love with innovation, this is why we love innovation, because for all of us who've had those uncomfortable discussions with patients in that we've not been able to offer meaningful therapy, we're having those conversations less frequently. I think we're better able to inform our conversations with a biological understanding, sometimes on a molecular level, of the diseases we treat, and better match our patients to the therapeutic armamentarium that's available. And I look upon this with extraordinary hope. Again, thank you very much for your attention, and I'd be happy to answer any questions that you might have.
All right, that was fabulous. Great. You wear multiple hats, and one of your hats is around value.
Yes.
If you were wearing the value hat and just heard your presentation, what would you take issue with?
Well, I think we have to put all these therapies in their context. So I think one of the issues that Dr. Zafar raised was, should we offer therapies to patients that don't make sense? And I think we have to be honest with patients where we don't have a satisfactory therapy, then we have to think much more carefully and be far more honest about palliative and supportive care as being the standard of care. But I think also as people working in academic medical centers, which is kind of the environment I work in, we have to be much more transparent about our value proposition. We have to, and again, I hate to keep spouting that word, that innovation is part of that value delivery. And we're looking at patients with ALL, for instance, delivering a cure has far more meaning than delivering something that prolongs life simply by a matter of weeks. And being able to differentiate between the two in a meaningful and transparent way, we have to create that language. And it doesn't exist in ICD-9 or 10 codes.
Joe, thanks.